Hi, this is Dr. Daly. Thank you for joining me for a brief protocol update for 2024. Before we start, a few thanks. Beth McGowan from ARAMS for writing the core elements of this brief training, Dr. Cushman and the staff, Monroe Livingston, for guiding our collaborative group forward, and Dr. Chris Foligar for his leadership on the Collaborative Protocol Committee. As we move forward, we're going to minimize the number of protocol updates that come out in order to make the process as smooth and reduce confusion as much as possible. New protocols will be in place every July 1st. The protocol committee welcomes input from new protocols or changes to existing protocols from clinicians across EMS. There is a link on every regional website to help update those protocols. When you do access that link, please give us as much information as possible about why you believe that protocol should be updated and any medical evidence that you may have that will help us through the process of deciding which protocol should change. For the last 35 years, the REMO protocols have included the statement that protocols are not a substitute for good clinical judgment. I don't think we can ever minimize the importance of this. Our protocols are a framework around which we provide care in the field. However, the clinical judgment of an astute EMS clinician is the most important thing to lead to a positive outcome for our patients. If you ever have any questions, please contact medical control for guidance and assistance. There's some global changes, including a new symbol, which is to refer to things that are if equipped and trained, a P for paramedic only, and some other reminders like intraosseous administration being allowed for EMT critical cares. Don't forget, with medical control, they may give you any order within the scope of practice for the provider. But a provider may only accept orders that fall within the procedures that are predetermined for your level of care. A CFR may not independently do glucometry. An advanced EMT may not administer controlled substances. That's actually by regulation and by law. And a critical care technician may never administer ketamine because of Department of Health policy. Pediatric definition is also important for us, that pediatric protocol should be used for patients who have not yet reached their 15th birthday. That may be confusing since patients will go to pediatric emergency departments up to the age of 18 or even 21. However, this is the way those protocols are structured. Remember, in anything requiring weight-based dosing, pediatric dosing should be calculated based on a per kilo basis, and the adult dose is the pediatric maximum dose. Use length-based resuscitation tapes, but do remember those length-based resuscitation tapes may have dosing on them that may be incorrect according to our protocols. Double check those doses to make sure that you're dosing patients appropriately. So let's jump in and look at some specific protocols with the ramifications that those protocols will have for care on a daily basis. We'll start with cardiac arrest. So about 20 minutes into a cardiac arrest, if you have not achieved return of spontaneous circulation, consider calling medical control for additional guidance. It doesn't matter if you're advanced life support or basic life support. Both should call for assistance. It's key that if that patient is in persistent ventricular fibrillation, or if they're in a narrow complex tachycardic pulseless electrical activity, the doctor may have some input that may assist with resuscitation of that patient. But if that patient is persistently in a bradycardic wide complex rhythm, or if that patient is asystolic, it may be time for termination. For a basic life support crew that can't see what that rhythm is. They may be part of the iGel placement project, in which case we'll have information from their end tidal CO2. But there may be enough circumstances to assist the physician with giving a termination order. Also key with cardiac arrest, that 20-minute guideline for resuscitation termination does not apply to pediatric patients, but at 20 minutes, it's extremely important to still call for assistance so that the physician's input can help with the outcome for that patient. A couple of changes in cardiac arrest for adults as well. Suspected acidosis as an indication was removed for a reason for giving sodium bicarb. That's true with one exception. If the patient is a death in custody following a struggle, we still suggest to start with sodium bicarbonate in that protocol. The only other reason to give sodium bicarbonate is suspected hyperkalemia. Defibrillation has been moved to every 2 minutes to make it more consistent. If there's return of spontaneous circulation, or maybe I should say when there is return of spontaneous circulation to be more positive, please contact the receiving facility as soon as possible to make sure that they are prepared for that patient. Acquire and transmit a 12-lead electrocardiogram so that destination can be selected appropriately. And paramedics get the added intervention of push-dose epinephrine. And there is instruction on how to prepare that push-dose epinephrine in the protocols as well. In the anaphylaxis protocol, we've changed it from anaphylaxis to anaphylaxis and allergic reaction. We've removed norepinephrine from the paramedic, and we've moved it to an epinephrine drip instead, since that's probably the more correct pressor to use in this setting. Epinephrine may be administered by autoinjector or syringe at all levels if equipped and trained. In the agitated patient protocol, we removed the requirement to call from law enforcement to make it a consideration, because every case will not require law enforcement. We did add utilize waveform capnography following administration of any medication in this protocol, because we need to make sure that we are monitoring our patients as thoroughly as possible. Recognize there is a discrepancy in the protocol, and that we say that if the agitated patient goes into cardiac arrest, refer to the appropriate protocol and consider treatment for acidosis. This patient, if they are agitated and go into arrest, should emergently be treated with sodium bicarb. We will be correcting that in upcoming update of the protocols. Do take a look out there, and there will be links on the regional websites. EMSC has created some fantastic information on calming pediatric patients. Calming a pediatric patient and calming an agitated adult patient are not the same processes. And EMSC brought some experts to the table to assist with this. For adult patients with bradycardia, we added an epinephrine drip as a med control option. Norepinephrine remains a standing order. And there's no need to give 2 liters of saline for bradycardic patients unless that patient is an inferior STEMI, in which case it may be necessary. There are a lot of comments added in here about hypothermia throughout the protocols, and heart rate may be slow is one of those considerations to think about here if that patient is hypothermic. Consider medical control consultation is always an important addition. For narrow complex and wide complex tachycardia, we've added that advanced EMTs can't utilize EKG to differentiate between these two. so they now have the same fluid bolus. We also remove vagal maneuvers because they're actually not a part of the educational scope. For ST elevation MI, we added to consider defibrillation pad placement. Do at least make sure anytime you're taking care of a patient who's having a STEMI that those pads are close, and consider putting them on the patient. BLS 12 lead isn't equipped and trained, as always. And for the advanced EMT, nitroglycerin, as long as the patient's blood pressure is appropriate. There's some specific ideas around ventricular assist devices. There certainly are more of these in the community, doing things like auscultating over the heart and stomach for that motorized hum that these can make, but also call the institutional VAD coordinator. These people have all of the information you could possibly need to take care of these patients. Under cardiac-related problems for pediatrics, we did suggest placing a cardiac monitor and perform a 12 lead if the patient has hypotension, or you believe that there's another cardiac-related concern. Of note, there was one case report written this year of a wide complex tachycardia that was discovered in a toddler by an astute paramedic placing a cardiac monitor on a patient in respiratory distress. For pulmonary edema, we no longer are going to be giving medications for bronchoconstriction, albuterol and Atrovent, because they probably didn't help. And actually, giving the beta agonist with the albuterol may actually have increased myocardial work. Paramedic has the added advantage of now having nitroglycerin IV in the protocol themselves. This is a fantastic addition because you can leave CPAP in place and still give patient significant high dose nitroglycerin and ultimately resolve that pulmonary edema very successfully. As I mentioned earlier, we're added a lot more information about hypothermia. This is actually a new protocol for both BLS and ALS. We highlight the differences between cold stressed, mild, moderate, and severe hypothermia, and then add protocols for each. There will be additional training put out around hypothermia, particularly as we get closer to the winter. Ultimately, please read this protocol, but for mild hypothermia, warm them. For moderate hypothermia, you're going to warm them. You're going to try to keep them horizontal, make them more comfortable. Do make sure to be careful of skin condition and be careful about burns. And for severe and profound hypothermia, in these patients, while you're going to do the things that you did for moderate hypothermia, but if these patients have no signs of life, you're going to do all of your cardiac arrest resuscitation, but more slowly and less. Only a single dose of medications, only a single defibrillation. Do recognize that rigor mortis, fixed pupils, dependent lividity may not necessarily be signs of obvious death in a hypothermic patient. However, do call a physician for guidance. Some pearls. Heart and respiratory rates are going to be slow and tough to detect in hypothermia. If that patient meets the trauma center criteria, they should go there. Pulse ox may be inaccurate, so these are challenging. If the patient appears to be in respiratory distress, do administer oxygen. Do a complete exam. You may miss things in these patients, but at the same time, while you're doing that examination, make sure to keep that patient covered and warm. And classification of hypothermia should be based on the clinical presentation. Oral, temporal, and skin thermometers, as well as otic or ear thermometers, are all going to be inaccurate in patients that are profoundly hypothermic. and it's extremely challenging for us to get true core temperatures. For localized cold emergencies, keep the patient warm. And if the patient is going to be just transported for less than 60 minutes, apply loose dressings. If the transport time is greater than 60 minutes, there are some directions for rewarming. Only rewarm localized injuries. So frostbitten extremities, for example, if there's no chance of that tissue refreezing. If you are not going to necessarily be able to keep that patient in a warm environment with those extremities warm after you have rewarmed them, please don't rewarm. Freezing and then thawing tissue can actually cause more damage. Heat emergencies. Somehow in the last set of protocols, we inadvertently removed active cooling. We apologize for that. We're not sure how that happened. And we removed the term dry because not every patient who's profoundly hot will have dry skin. Really important, if you've got a patient who is profoundly hyperthermic, cool that patient actively on the scene. If possible, rather than trying to transport them to the hospital and then cool them. You may have better methods of cooling that patient in a dunk tank, a large body of water, or something else, rather than bring them into an ambulance where you can't cool them effectively. We removed the references to water intoxication because if that patient can swallow and follow commands, go ahead and let them drink. We added a hospice care protocol, and we did this to assist with care of these incredibly complex patients at the end of life. We realized that we're dealing with two different sets of patients here. The first is the actual patient who is in hospice, and the second is their family. We have to deal with all of them as empathically and helpfully as we possibly can. Do recognize that there is additional training that's been done by folks down in the Hudson Valley as well as by Monroe Livingston providers, set up by Dr. Dorsett out in Monroe Livingston. This training is fantastic and I recommend it for everybody. Some pearls of wisdom in that protocol. Goals on how to handle breakthrough pain, how to handle anxiety, opioid-related constipation, which is not something that we normally talk about, fever, confusion, delirium, bleeding in the oropharynx, and terminal dehydration. These are very challenging, and do recognize the moral toll that taking care of a hospice patient or any patient at the end of life can take on EMS providers who may not be prepared for that. For opioid overdose, we adjusted language. There are multiple different units, doses of naloxone that are available out there. There is no approval for the use of naloxone in doses greater than 4 milligrams in the pre-hospital environment. Pre-filled syringe, so the 2 milligrams and 2 mLs with an atomizer is a unit dose, and that's fine to use. Again, that 8 milligram intranasal dose is not approved for EMS because of research done by the Department of Health, which demonstrate that 8 milligram naloxone dosing leads to increased symptoms of withdrawal. We had another opioid antagonist, a drug called nalmefene, on our formulary as an alternative to naloxone should there be a shortage. That drug has actually been removed because it has an extended half-life and leads to the potential for long-term withdrawal symptoms and misery for that patient who has received it. The Chempack program themselves, this is a federal program. It has nerve agent antidotes, atropine, 2-PAM, diazepam, and this is a program that is regionalized throughout the state and throughout the country. There's additional training that's available on this. However, we've updated the protocols to more accurately reflect what the Chempack program does. It's interesting that actually you can call out for the Chempack protocol if there is only one patient with severe organophosphate or nerve agent toxicity. So if you have a patient who's been impacted by an organophosphate fertilizer exposure, for example, and has symptoms of salivation, lacrimation, urination, diarrhea, GI distress, emesis, muscle twitching, and meiosis, the sludgem symptoms, you can certainly call for release of the Chempack. You may have that patient to the emergency department prior to its release, and its release should be to the emergency department, but recognize these patients will likely need to be decontaminated, so there may be an extended scene time. So it may be very helpful. You'll note that the Chempack can be used by all levels of provider, and that's the way they're designed to be used. These are a series of auto injectors. The most important thing on this is to make sure that you're using appropriate PPE and these patients are deconned effectively. This is what the Chempacks look like in some settings. Each agency and crew chiefs within that agency or chief officers should know how to request elements of that Chempack. We have exciting changes in the pain management protocol. One is the addition of acetaminophen IV, which can be a very helpful adjunctive agent and reduces opioid use. The other is the addition of standing orders for intravenous ketamine at a dose of 25 milligrams IV or 50 milligrams IM specific to pain. When I give the ketamine, I actually put it in a 100 bag and I drip it in over 5 to 10 minutes. If the patient gets relief or if the patient has any side effects, I can slow that drip down. I find that to be extremely helpful. But this is a great adjunctive way of taking care of pain in adults. In order to use more than one agent of the control class, so morphine and fentanyl, fentanyl and ketamine, that requires a phone call to discuss this case with medical control. For pain management in pediatric patients, ketamine remains a medical control option. So for those patients under the age of 15, if they're remaining in pain after getting opioids or you want to avoid opioids, please make sure to call medical control for considerations for ketamine. IV acetaminophen is still an option. Post-intubation management, really important to remember that if you are choosing to use rocuronium as your paralytic for intubation, recognize that this is going to require at least 30 minutes of sedation after that intubation is complete. We decreased the ketamine dosing frequency to every 15 minutes, which is about what that drug lasts. We changed the midazolam orders because you can give less than 5 milligrams of midazolam. But do recognize that if that patient has received rocuronium, you must have a sedative plan for that 30 to 45 minutes that the drug will last, as that patient will be paralyzed. It has the potential to be paralyzed in a week. For seizures, we clarified that these patients should be getting 10 milligrams intramuscularly or 5 milligrams intramuscularly for active seizures. Magnesium should be administered after midazolam in the pregnant patient because we have to stop that seizure first and then raise the threshold to prevent the next seizure. So regardless of whether that patient is pregnant or not, the first agent that they're going to receive is midazolam. And as a medical control consideration for paramedics, ketamine could be used as well. The thing to really watch for a patient that gets ketamine after 2 doses of midazolam would be respiratory depression. These patients at that point must be on end-tidal CO2 in order to manage, really watch the management of their airway. I would also note that this really is one more indication of ketamine that is really important, because we don't have a whole lot of other options to benzos, and benzodiazepines have gone on shortage quite frequently over the course of the last 4 years. For seizures in pediatrics, we've adjusted the midazolam dosing to be appropriate, and we added ketamine under medical control considerations as well. Working with the Regional Trauma Advisory Committee, we've added the protocol for open fracture treatment with antibiotics. This will be with cefazolin or Ancef, 2 grams IV for adults with open fractures. This is approved in the REMO and REMS regions, and that's if there's greater than an hour of extrication to arrival time in definitive care. This is hopefully going to make a difference in the outcomes of our trauma patients with open fractures. For trauma-associated shock, we've removed references to compensated and decompensated shock just to make it easier. If the systolic pressure is less than 100 or the MAP is less than 65, we're going to give 500 milliliters of saline. We'll repeat that in order to maintain that systolic blood pressure of greater than 100 or the MAP of greater than 65. So those are our goals. Advanced directives, including DNR and MOLST. The EMS provider can now follow the direction of the healthcare agent if they're present on the scene, or available by phone when the patient lacks decision-making capacity. Remember, Public Health Law 29 allows the EMS provider to follow the direction of these folks, and if you, in good faith, are following what you believe are the wishes of the patient, you're indemnified. That is really important for these patients at the end of life, to make sure that we are following their wishes. There's some really good training available on Vital Signs Academy on the new medical orders for life-sustaining treatment. For prescribed medication assistance, I still refer to this as the Do the Right Thing protocol. You may administer any patient-prescribed medication as long as the route of delivery is within your scope of practice. Assist the patient, assist the patient's caregiver, and that way the patient will have the best outcome. So with that, I say thank you. I think we have some really good updates to these protocols. I think they are continuing to grow to serve the patients of New York as effectively as possible. And these are exciting times for EMS. In our future, hopefully we will have EMS administered buprenorphine for opioid withdrawal symptoms at some point. We will have EMS-initiated blood transfusion at some point in the future as well. These will be great advancements for our patients. These could not be possible without the professional EMS clinicians that we have in this region and others across New York State. Thank you all for what you do every day.